Everyone, welcome back to another Sagely Health webinar. As always, I'm Jeremy, CTO of Sagely Health. I am joined by the founder and CEO of Sagely Health, Jason Sager, MD. Jason, how's it going today?
Going well, Jeremy. Thanks a lot.
So we've made some time today. We recently had a patient who had come to us, not exactly a patient. They had worked with us previously, and they came to us because they had a BRCA mutation. And they wanted to know what they could do to be as proactive as possible. And that's something where we started doing research and we started kind of revisiting the topic. And we kind of realized this is something where people don't really understand this very well. And I think everyone kind of has a surface level of understanding of it. So it's something we really wanted to dive into today. So the topic of our webinar today is about BRCA. So let's just start with the basics. What is BRCA?
Yeah. I think everyone's heard about the Angelina Jolie story, and sort of that made BRCA somewhat more famous, which is good because it raises awareness. But it's really important because BRCA is one of a family of DNA repair genes. And on my screen, you can see that in our chromosomes, we have two chromosomes, or two different chromosomes, two different genes. One is for BRCA1 and one is for BRCA2. BRCA was actually named for breast cancer gene. And so, because they saw it associated with breast cancers, but they didn't know why. What we know now is that these genes go and repair DNA in our bodies. And actually, I'll show you a little bit of a walkthrough of that. In each of our cells, there is DNA, which is the genetic code that makes up all of the proteins and everything else that represents who we are. As one goes through life, that DNA can become damaged. And when it's damaged, it's important that the cell have a mechanism for repairing that damage. The cell actually has multiple mechanisms. There's one called P53. There's one called BRCA. We'll learn about one called PARP a little bit later. And these factors, these proteins work with each other in order to kind of slow the cell down. If it has DNA damage, it says, wait, don't divide. And at the same time, it stops, repairs that damage, and says, go right ahead. And so you could see here on the left, in a normal cell, you might get damage, and that might happen from the sun UV rays, or it might happen from just random getting older, and these things accumulate. But importantly, BRCA goes to work, and you see that it's proficient, meaning it works well, and then that DNA is repaired. When there is a problem with BRCA, a mutation or something else, a genetic alteration that knocks out how it functions, then the cell doesn't have as much of a chance to repair. Remember, there are other repair mechanisms, so it might still repair, but it might not. And in that sense, there's a few mutations, a few DNA damage, which mutations or other alterations that sort of sneak through. Those can accumulate over time. And what we know is that cancer is basically the result of accumulated genetic changes or alterations that basically do not serve the body well, that cell well, but it enables them to grow and really divide much more uncontrollably, and that's cancer. And so
Okay.
the
Let
more
me
you have,
stop you.
yeah.
Let me just stop you 1 sec, just in case I don't want anyone to get lost, because we didn't kind of lay a foundation for this. So I have trillions of cells in my body. Each one of those is at some point going to replicate, meaning make a copy of itself, get rid of the old version, and we got the new cell. And so the way that the cells are doing that is there's DNA, and I guess you have your DNA is in every single one of those cells, and that's kind of the instruction saying, hey, this is what you're supposed to do.
Right.
And so when you say that the DNA gets damaged, you don't mean the DNA in all of my body. You
Right.
mean DNA in just some cells.
That's right. That's right. And they're random. It could happen to your, again, usually random. If you get, hit by sun exposure too much and you get a sunburn,
Right.
well, then your cells on your skin are being damaged. And that damage both is turning the skin red, which is what everyone can see, but it actually means that there's DNA damage inside the cells because the sun's rays has hit them and caused breakages that need to be repaired. That's an
Okay.
example of the type of
So
damage.
so it's kind of like the cells are doing what they normally do, and something goes wrong. And so either a sun ray or an X-ray hits you,
Yeah,
or you're getting older and you've just done
yeah,
this trillions of times, and today it didn't go right. And so when that happens, what you're saying is BRCA is like involved in saying, "Oh, whoa, something went wrong. Let me fix that." Is that
right.
is that how I should
That's
understand that?
exactly right. That's
Okay.
exactly right. And again, it's one of maybe a dozen or so members of this DNA repair shop. So you've got like a whole shop toolbox, and altogether they coordinate to try to keep the cell in as good of a state of repair as possible.
Okay. So your cells are maybe just considered a little handicapped if the BRCA gene isn't
Yeah,
working.
so
Is
you're
that
right.
a way?
That's right. That's right. And so the fact is that any one day of the week you won't necessarily see something wrong, but over someone's lifetime, let's say 30 or 40 years, enough of that damage can accumulate and not be fixed that results in a higher probability or possibility of getting cancer or having one of your cells convert to malignancy, becoming cancer. And so that's where it's known as a cancer gene, because people who have a BRCA mutation or deficiency have a higher chance of getting cancer than the general population. And interestingly, it's specific for some cancers. So breast cancer, ovarian cancer, colon cancer, pancreatic cancer, and a couple of others.
Okay, so because now when we talk about someone having a BRCA deficiency or a mutation and their BRCA gene isn't working that well, we're actually talking, in that case, we're actually talking about every cell in their body. Their copy of DNA that's in every cell of their body has an issue with BRCA. And so that means that that's affecting all the cells in their body. And it sounds like with the cancers that you're talking about, those are the cells that it actually seems to affect, like breast tissue cells and that
Right.
sort of thing.
Right. So usually a patient who has BRCA wild type, meaning no mutations or alterations, right, they might expect to have about 12% chance of having breast cancer. In BRCA deficient patients, their numbers can go from anywhere from 40% to somewhere upwards of 70% or 80% in their lifetime of having breast cancer.
Wow. So the way that this was discovered is once we actually had the technology to look at genes and go in, you say, oh, very interesting. Like all these people who got breast cancer also had this gene mutation.
Yeah.
And that's just to get it out there is the name is the breast cancer gene, BRCA breast cancer. And so that's why it was named because it seemed really clear that these two things were tied at the time.
Yeah.
So what's BRCA1 and what's BRCA2? Because I see
Yeah.
both of those out there and
Yeah.
I'm a little
Yeah.
confused about
So
that.
again, they are actually separate, right? Those are two members of this family or this class, this group, the shopkeepers who basically, do the DNA repair. So other than the fact that they've got similar names, they actually functionally are different, except they do the same thing. They're definitely helping the cell to stop this DNA damage and repair it, but in slightly different ways. And what that means is that the 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 relationship between getting a BRCA1 and having a higher chance of getting breast cancer or other cancers is different than BRCA2. And so we begin to dive into some of the specifics. And you could see, for example, that BRCA1 deficiency, those patients or those people will generally get cancer between 30 and 50, where for BRCA2, it's more between, 40 and 60, things like this. And, we now know that they are different, but they are similar in that their function is both in helping to repair DNA damage.
Okay, so they both got the BRCA name because they had a correlation with breast cancer, and the
Right.
name seemed to make sense at that time. Now we kind of know it's involved in other cancers as
Right.
well, but the name still remains.
Yep.
So how many people? I mean, that's a really heightened risk, like an enormously heightened risk if you have a BRCA mutation. So how many people are walking around with a BRCA mutation?
Yeah. Here, there's been a number. This is from the National Cancer Institute, and if you look across all populations, it's not that high. Somewhere between 0.6 and 3% of the population would have this, depending upon where you look. However, when it comes to the certain groups, for example, the Ashkenazi Jewish population, they have higher. So they'll have, for example, 1 in 40 um, in terms of numbers of people. So one person for every 40 women who have this, who are an Ashkenazi Jewish population, will have a BRCA mutation or genetic alteration.
Yeah, I was looking at the numbers, and I was very I was very surprised how high the Hispanic population was. It was around. It was the higher range. It was like 3.5%, which to put in context is kind of like 1 in 28 people. So okay, so it's not insignificant. This we're not talking just a shade of a percentage. Like this is a significant number of people
Yeah.
in the world. So let's. I know you mentioned it before a little bit, but can we talk a little bit about how much is this increasing your risk of cancer and kind of like, and I know it affects different types of cancer, but just like how should one understand how heightened one's risk is?
Yeah, yeah, and 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 again, if you look at the two differently, for BRCA1, this is responsible for about 35% of hereditary, meaning inherited breast cancer. Again, the general population has a 12% chance of getting breast cancer. In this population, by the age of 70, you could see that depending upon the specific change in BRCA1, and we'll get to those details in a moment, it would go from anywhere from 44% to as high as 78%. If you look at in ovarian cancer, 18% to 54%, and then male breast cancer also increases, although still very low, but higher, much higher than it, tenfold increase than it would have
Yeah,
been otherwise. And if you look at BRCA2, similarly, this accounts for a little bit less of hereditary breast cancer. Uh, the ranges go from 31% to 56% by 70, gets up to about 69% by 80. And then ovarian cancer, a little less than BRCA1. And then male breast cancer, actually more. So about up to 12% of people would have male breast cancer if they had a BRCA2 mutation.
wow. So you have a really heightened risk, and so with that, I begin to understand some of the preventative things that people would do. So um, first, let me ask about kind of who should get tested for BRCA. I mean, we're talking about a certain percentages of people, and these are large swaths of the population. So, how do you think about if you should get tested for BRCA?
Yeah, it's a great question. And actually, again, there have been many historical studies about this. There was actually a group in the United States, part of the CDC, called the United States Preventative Services Task Force, who basically were tasked to look at this question: who should have genetic testing for BRCA mutations or alterations? And what they came out with was a list of recommendations that I'll show on my screen here. For non Ashkenazi Jewish women, any time you have two first degree relatives with breast cancer, one of whom was diagnosed at age 50 or younger, that's an indication to get tested. If you have a combination of three first or second degree relatives with breast cancer, regardless of their age, and you can keep on going there and see all of the others. A history of a male relative with breast cancer is an instantaneous reason. For Ashkenazi Jewish women, a lot of them are getting tested regardless. And frankly, the sagely health approach is to be proactive and to get tested no matter what. That being said, the recommendations here is any first degree relative or second degree relative on the same side of the family with either breast or ovarian cancer. And so that's really important for Jewish women to know.
Well, that's okay. So it's a inherited genetic condition. So that makes sense that you can use members of your family, previous diagnosis as kind of signposts of what you should do. That's really interesting. And then the other thing I just want to point out, if it's not clear, is you get tested for BRCA once. That's it. You're not. It's not a yearly thing. It's nothing. It's literally you inherited a gene mutation. You have it. You'll have it your whole life.
Yeah. Yeah,
Um,
yeah. No, actually, and just to know, not all of them are inherited. There are
okay.
spontaneous mutations that happen in BRCA, but about 95% are inherited. About 5% are what they call spontaneous. So, meaning there was no relations that were known of before. And the way they know this is they'll see someone who is BRCA mutant or deficient. They'll go back and test their parents, and the parents are both wild type. They're both without any alterations. And they
Okay.
know that person was a de novo or a spontaneous mutation.
Okay. So we'll follow that in. Can happen. Not
Can happen, but
that
probably
common.
not. Right.
Yeah.
Most
Okay.
likely it came from someone. I just like, if someone gets breast cancer and they get tested, I don't want them to say, like, well, no one else in my family had this. Well, there are spontaneous, but most of the time it's coming from one of the parents. And again, it's variable expressiveness, meaning not everyone, again, it's a higher chance of cancer. It doesn't mean it's absolutely going to happen. So it could skip a generation, it could skip several people. It may not be the easiest thing to figure out. And that's where they try to figure out this combination of risk factors, which say it's worth getting tested. And again, for people who are really proactive, especially for those who are Ashkenazi Jewish, it's probably reasonable to get tested.
And you can do this is a blood test, a saliva test. Any
Yeah,
of those can do it, right?
one of the two.
Okay.
And this is the sort of thing that some of the famous testing companies, um, you know, you know, um, there's one called Color Genetics. They offer one of the tests. There's a bunch of them, and the doctors have these tests. So if you
And,
go in and request this just from your family doctor, they might send you to a geneticist, which is nice and important because you want to have counseling around this. But the fact is that the tests are pretty easily available.
okay. So if you go get tested, it can come back and say, as we said, wild type, meaning you don't have a mutation. You have a normal BRCA gene. And by normal, we mean that's what the population has. And you have the same ability to repair damage as others with that BRCA gene intact. Um, but it sounds like when you have a mutation, either in the BRCA1 or the BRCA2 gene, it could be a different mutation. Not everyone has the same
Yeah,
type of mutation, right?
yeah. And what and what we know, and there's been this was quite a good article. This is the Gen Test Review. There's another one. This one was from JAMA, and they actually studied almost 6,000 people from even more actually. So it was 10,000 people um, for BRCA1 and BRCA2 mutant carriers to figure out what are the risks. And this is where you could see the risks plotted out right here for breast cancer and ovarian cancer. Those are the primary two. Again, pancreatic cancer can happen, colon cancer can happen, but these are sort of the big two that physicians worry about the most. And you can see that the risk increases over time of getting it, upwards of around about 70% here at the end of 80. Um, what we know now is, and I'll just scroll down here. Um, we can come back to some of the others, but there's a host of different changes. So this is the BRCA1 list. This is a 5' to C2281. There's all sorts of changes, and each one of those has a different risk factor. If you scroll to the sort of the right side here, you could see that that this one has an 84% chance of actually having breast cancer by the age of 70, versus this change here has only a 39% chance of having breast cancer at the age of 70. So the details matter. And what I'd say is once you get that test done, based on its results, if you are found to have a mutation or an alteration that is called deleterious, meaning that the expects that the protein is no longer working, then definitely get some counseling. And of course, some patients come to us to find out, what they should do. Just to point out, this is the actual change it was one of the founder changes in that Ashkenazi Jewish population called 5946 del T. And again, you could see that this is, I think, in ovarian this is breast cancer. Yeah. And so they have about a 41% chance. But again, you could see that the number of patients studied here was pretty small versus like 967. And so you could see the range can go from 20 to 70. That's not very satisfying. And
Yeah.
I'd love to see more data that gets us to a more accurate number, because these are some pretty major considerations, and we'll talk about what to do in a situation where there is a BRCA1 or 2 mutation.
Yeah, so I think I would encourage anyone who's found that they're BRCA positive to kind of say, do you know any further details about it? Because, others could probably help you. We could help you at Sage of Health, but genetic counselors, and you could probably do some research on your own. But there is probably a little more you could know about it. So once we get into that, if someone's facing, they have a BRCA mutation, they may know some details about it, but what's the recommendation? What does a man or a woman do if they find out they have a BRCA1 or a BRCA2 mutation?
Yeah, and from my perspective, this is one of the things that we were asked by this patient who came to us, this person who came to us, and when we delved into it, there's several categories of things that can be considered. The first thing is what they call is enhanced surveillance, right? So this is a situation where you want to be screened and scanned for breast cancer, for example, fairly frequently. And what does fairly frequently mean? It means that, first of all, every woman gets a mammogram every year. In this case, there's a separate second test called an MRI. Most people know what an MRI is. It's a special type of scan. It's with magnets, and it's the noisy one where you're sitting in the
Right.
tube and you hear all kinds of clunking. Um, that happens. So for women who have BRCA or BRCA carriers, they'll get an MRI every year and they get a mammogram every year. And what's good is that they'll alternate. And so really you're getting one test every 6 months. And that goes on pretty much indefinitely. And it's really important because even if we talk about some of the other risk reduction steps, it's really important to have, it doesn't remove all the risk. So it's really important to have that enhanced screening tests. Um, in addition to that, there are new tests that are coming out, and I just wanted to kind of name one of them, which is called GRAIL, and they're looking at in blood for circulating tumor DNA, and they're offering that to healthy people right now. Here, there's a heightened risk of cancer, and so it makes a lot of sense for someone who may be on the fence, because I think it may be $1,000 to get this sort of test from GRAIL. That can be a lot of money for people. Is it worth it? Well, every couple of years, it could be very much worth it for folks of heightened cancer risk. And the reason is because ovarian cancer
Yeah.
and pancreatic cancer are two of the cancers that are picked up really well by this test. They're really hard to find without a test. And so, that's the sort of thing that can be really useful. And I just wanted to throw that out there because not a lot of doctors or genetic counselors are currently recommending GRAIL to those patients, but I think it's really important for them to consider.
There are some other tests, I think like a CA125, or I don't remember the exact number for
Yes,
breast
that's
cancer.
it.
But that's another blood test where it's not definitive. It's not like a yes no, but you might be able to like monitor some levels. Is that
Yeah,
something that
there
applies?
there are other tests like CA125 that's specific more towards ovarian cancer. The
Okay.
ones for breast cancer aren't really standard today, so it'd probably be harder to find. But the imaging is good for breast cancer. The
Right.
CA125, unfortunately, there's lots of things that make it high or low that are not having relationship to ovarian cancer. And so in general, it's not used as a screening test. If someone is diagnosed with cancer, they can be used to follow their cancer if it's positive. But that's where the GRAIL test, to me, sort of is better. And not only that, but it also detects multiple cancers like pancreatic cancer as well.
Okay, so if you have a BRCA mutation, then there are heightened screening for whatever
Mhm.
screening you can have, and hopefully things continue to advance. We have more better and better screening for everyone. And if you have a BRCA mutation, you probably just do it more
Yep.
often or more likely to do it.
Yep. Yep.
And so that's preventative in that way. And just to point out to everyone, I mean, the idea is that if you catch cancer early, when it's local, it hasn't spread, surgery is generally an option, which is kind of the known possible cure for cancer. And so if it doesn't spread and you kind of cut it out, you're in
Yeah.
much better shape. So
Yeah.
just the outcomes, the data
Yeah.
doesn't lie.
And
The outcomes are
yeah.
better.
Yeah, and we'll talk a little bit more about that. But the fact is that when if people with or who are BRCA carriers get cancer, we know there's cancer is no more aggressive than anyone else's cancer. So
Okay.
it's still you can still catch it early and do something about it. It's just that the likelihood of having it is so much more, and so it's more of a matter of time than it is necessarily whether or not you'll have breast cancer and that sort of those sorts of things.
Gotcha. Okay, so then let's talk about. Well, you can tell me where
Well,
else you want to go, but I'm
yeah,
thinking
yeah,
about preventive surgeries
yeah,
as
yeah, yeah. So
I kind of
yeah,
go
so
in.
there's a second class of prevention, and right, it's what they call the risk reduction surgeries, and they come in two forms basically. It's bilateral mastectomy, and this is where again Angelina Jolie elected for this and had this done. And then the second one is a risk reduction and removal of the ovaries and usually the associated organs like the fallopian tubes, sometimes the uterus. And so that's another surgery. And what's really, I think, what's critical to think about is nowadays with the technology that's available um, for reconstruction, breast reconstruction. I think and we went through a period where they weren't the quality wasn't so good, but now things have improved, and so we're able to really help women to remain whole as possible. No one really wants this sort of thing to happen. But in terms of the risk reduction, it's 95%, right? So if you have bilateral mastectomies, your risk goes from basically that high of whatever 69% all the way down to about 5 or 6%. So actually lower than what normally might happen. Again, still recommend the heightened surveillance because it's still there, but it's a tremendous risk reduction, and many women decide to go that route. Some women do not, and that's something that to talk about with each individual counselor and doctor. But also from my perspective, it matters in which change you have, because if you have something that has a 90% chance of happening versus a 30% chance of happening, that might determine which way you go in terms of these risk reduction surgeries.
Yeah, so I think the mastectomy. Obviously, there's a lot of women who've had it done, and so it's something where you could there are support groups and there's kind of people you can talk to about that. And I think that would apply almost anyone at any age. And so I just want to kind of ask about a delicate subject of family planning. So if someone was younger and they found out they were BRCA positive and a woman had a plan to have a family, and so is this something that would prevent her from doing that? Is there anything she should kind of think about with that?
No, I mean, again, it's important to get the surveillance, but while doing so, again, the risk of getting it when you're under 30 is quite small. It could go up in your 30s, but most of the time, childbearing years are between those ages. And so when a woman is done with the childbearing years and or hits menopause, oftentimes that's when these things are considered. And I think Frank, our person had been told when she was 45 she should have this done, and so that's not an uncommon age to recommend something like this risk reduction surgery. There can be some things that influence it though, and one of the things that I know has come up for us is the question of hormone therapy and hormone replacement therapy for women in going through menopause. And again, menopause can be quite difficult for some people, and so it's important that you be supported. But because we know that hormones are connected to breast cancer and can stimulate breast cancer, especially when unopposed. So in the case of breast cancer, it's progesterone that can stimulate its growth, although estrogen also drives things. But in terms of the replacement patch, that's what's sort of doing uh, increasing the risk, and then estrogen for uterine cancer. And so, so from our perspective, it's great if you don't need to have to be on that replacement if you have a BRCA, if you're a BRCA carrier, and it's
So let
something
me
to
let me
work with your doctor.
So what you're talking about here is that when a woman reaches menopause, she may have side effects or
Yep, hot
think,
flashes.
yeah, just symptoms of things. And to deal with that, there are treatments, which are hormones, which are like hormone patches and things like that,
Yeah,
where you're replacing the hormones you're not getting, and then that's there. But you're saying that the use of those hormones could increase your risk if you were
that's
a BRCA
that's right. That's right.
carrier. Yeah, so let me just ask about that. So I understand that we have like definitions of some breast cancer, ovarian cancers are ER positive, PR positive, and that means that these are cancers that are using estrogen or progesterone to grow, to
Hmm.
actually using it.
Right.
So it's not just a risk when the cancer is developed; it's actually a risk of forming the cancer.
Yeah, in that transition stage. Yes.
I see. Okay, well that's good to know.
Yeah. Yeah, and actually, in our doing our research, we found a new drug that was just approved for menopause and hot flashes. Specifically, that's non-hormonal. So it's a sort of thing that if there are now kind of better options or newer options, not necessarily better, not necessarily easier, but something again in the situation where there's BRCA to work through them and to see if that will work as opposed to having to have the patch and have a higher risk.
So I think we've covered this, but I just want to put it out there to be very clear. Is there any way you can be pre-treated, in the sense that if you have a
Yeah.
BRCA mutation, you're worried about getting cancer, we're talking about things to prevent the cancer from happening, but is there anything else that can people get some type of treatment? Can you be treated
Yeah,
for having a
yeah,
BRCA
yeah.
mutation?
It's a great question, and the answer is that it's treatment for breast cancer, positive breast cancer, is tamoxifen, and tamoxifen can actually be used in BRCA carriers and has been used. It does reduce the risk. Now, again, if someone's going through menopause symptoms, then tamoxifen's not going to help with that. It's going to probably even make it a little worse. That being said, if there's no, if not, but let's say a woman does not want to have the breast reduction surgery, tamoxifen is an option. It reduces the risk by about a third, by about 30%. And so you might go from that 69% down to about 30 or 40%. There's still a substantial risk compared to the normal population. And so, but again, that those are individual choices, whether you go with the risk reduction surgery or something like a preventative like tamoxifen.
And we've talked about we were talking about hormone replacement, but are there any other kind of lifestyle choices you should be making or
Well,
considering if you
we,
are a BRCA
yeah,
carrier?
I mean, well, before we leave the topic, I did want to mention that again, there's another surgery which is the ovaries, removal of the ovaries and the fallopian tubes, which is also fairly standard. Once you don't need the hormones being created by them, and you're not planning on any more children, then certainly that can reduce the chance of getting ovarian cancer or any of its sort of spin-off cancers, I'll call them, but basically fallopian tubes related cancers. So fallopian tube, ovarian cancer, and a third one called primary peritoneal cancer are all related to the same sort of cell of origin. And so we'll talk about that a little bit more later. But that's another risk reduction surgery that's available to women. And it's a very easy surgery. It's usually a laparoscopic surgery. It takes an hour or so, and it's an outpatient surgery. So with or without the hysterectomy part, the removal of the uterus, those things can all be considered.
So a woman would have to prioritize them in some way. Like I hear a lot more about mastectomies than I do about removal of the ovaries or removal of the uterus. And there might be reasons for me hearing more or less about that. But how would a woman kind of think about it? Is it like, let's go do it all this week? Let's, stage these surgeries. I mean, is it, let's do
Yeah.
them over years? I'm just curious if there's kind of a strategy that
Yeah,
they can
I
deploy.
mean, I'd say it's the sort of situation. There's no emergency, right?
Right.
And at the same time, the clock is ticking, and so Usually, I would say it would be rare to get the two at the identical same time. Usually, they're staged. They might be a year apart. Some people might get the ovaries done first and then the breast. Some people might get the breast surgery first and then the ovary surgery. And again, various doctors, their availability. There's a number of things that could determine, all of that. And so, but over time, over a couple of years, it would be good to attend to both if you're in that age of heightened cancer occurrence, right? In the 40s and 50s, and certainly then the 60s.
Yeah, as you show those charts kind of going up and to the right, as you age, the risk increasing so much, I have to imagine that the time when you discover you are a BRCA carrier has a big play into how soon and how dramatically you
Yeah.
think about the surgery.
Yep. Yep. And you mentioned other things. What other lifestyle? Obviously, a healthy lifestyle is always recommended. You don't have to be a BRCA carrier for that.
Sure.
Not smoking, for and we talked about the risk of estrogens, but the risk of smoking is much much more than the risk of estrogens. Um, making sure you get your screenings, making sure that you're taking care of your skin, that you're getting a bone density scan, and supplementing as needed. The colon cancer screening is obviously really important here, with a colonoscopy or the newer test from Exact Sciences called Cologuard. That's an alternative option for folks. But really keeping up on those, I think, is quite helpful and beneficial.
Yeah, I just say to people, over the past few decades, there have been changes into the guidelines for screenings. And I would say that primary care doctors are a little varied in how aggressive they are in asking patients to do these things. So it's one of these things where you do have a little bit of the responsibility on yourself to have the screenings and to know. I mean, as I've gone for a colonoscopy, it was not something I wanted to do, but working in sexual health, I understood the importance of it. And I
Yeah.
think that, we're trying to raise awareness for those.
Yeah. And I had a Cologuard during the time of COVID when, there weren't a lot of colonoscopies happening. And then, mine was negative. And then I went for my colonoscopy when those reopened again after COVID, and just a couple of years ago.
Yeah, so let's switch gears a little bit from kind of this idea of having being a BRCA carrier and kind of what actions can you take to, we have people who've registered who are, they have been diagnosed with cancer and they have a cancer that it was inherited BRCA mutation cancer. So you answered one question which I was really interested in, which was, is having a BRCA driven cancer, or meaning that BRCA is involved, like, is it more aggressive or is there something special about it? And I think you said that no, it's not.
It's not a more aggressive. There is actually something special about it, though, in that there's a medicine that can be specifically used for BRCA uh, cancers that is not used with other cancers. And so this entity is called a PARP inhibitor,
Okay.
and there's a number of other innovative innovations that are coming down the pike in terms of clinical trials that are quite exciting for folks that want to do even better than what the PARP inhibitors are doing. But the PARP inhibitors themselves, when then they work alone, they work fairly well. Now, it's not a miracle cure, and so if there's metastatic disease, this is just delaying, the inevitable. But it does add potentially years, and so that's really good. Um, and so just to bring you through that, PARP is again another repair enzyme. And you can see here on my screen, you've got BRCA on one side and PARP on the other. And so a healthy cell that has damage, because they all do get damaged once in a while, randomly, they'll be able to repair that. If you knock out the BRCA, remember I said sometimes a mutation will sneak by, but frequently PARP will actually help to recover that. Now, on the other hand, if you have a normal cell and you put a PARP inhibitor in, BRCA still works in that cell, and therefore it's repaired. Only if there is basically a cell that has a BRCA deficiency and is now in a cancerous state, and then you use PARP, well, then now that cell goes to cell death. And so you're selectively able to kill cancer cells that basically normal cells and even cells with only BRCA but not cancer, they're able to do fine. Um, these PARP inhibitors have been around for quite some time. One of them is called olaparib. There's niraparib. There's a few of these. Um, the issue, and Lynparza is the name of the olaparib for the trade name. The issue here is that they've been difficult to combine with other medicines. As soon as they do, they hit another cell that's rapidly dividing, which is the bone marrow cell, the blood cell, basically. And so your white blood cells go down, and people have trouble fighting infections. When used by themselves, they can be, there's some side effects sometimes, some GI, nausea, and that sort of thing. But most of the time, it's fairly well tolerated, depending upon what dose is chosen. And people can live on these for about 2 years or so. After that, there's a chance of a secondary cancer happening, so they stop it at 2 years. And this is where there's a number of newer agents that are coming down the pike, one of which is a PARP1 selective inhibitor. And so now they're even diving into the difference between PARP1 and PARP2 and seeing, can we help patients without causing some of those side effects?
And that's in trials now.
And that's in trials now. And the data is looking pretty good, and we're going to continue to see how that goes. There's other companies that are trying other mechanisms to try to help in these DNA repair pathways. So USP1 was one that's looking kind of toxic. So there's others that are coming down the pike that are looking pretty exciting in terms of the ability to combine, perhaps with a PARP inhibitor, to help those patients with BRCA alterations.
Excellent. So with the PARP, you might be treated with that. You might be able to do that up to 2 years, and then after that, you would then switch to maybe a different type of therapy to
Yeah.
continue as needed.
Yeah. That's right. That's right. And it might be in the setting where the cancer comes back or grows again. It may be that it's still considered maintenance, which is the way these PARP inhibitors are used. So usually there's chemotherapy, sort of hard hitting stuff first,
Oh,
and
gotcha.
then like the taxanes and the platinums and things like this. And then the PARP inhibitors are used sort of in between as maintenance. And then there's something else afterwards if needed.
Excellent. So that's great. I think we've covered kind of the topic overall. We did have some questions submitted that I just want to look over to make sure that we address them. One was a little outside what we're covering, but it was asking about ovarian cancer, kind of updates on treatment options. So I'm assuming this is a BRCA carrier with ovarian cancer, and so she was asking like, what are the most recent treatment options out there?
Yeah, yeah. And again, this is a little bit different. Again, we specialize at Sagely Health in these innovative approaches, clinical trials, what's going on out there that's coming down the pike for future treatments. And so we're always on the cusp of remaining aware of all of these sorts of advances. And what I'm showing here on my screen is a drug called AZD 5335, and this is a second generation of what's called a folate receptor antagonist antibody drug conjugate. That's a whole mouthful, but we've recently been published or are in the midst of publishing a article on antibody drug conjugates. So I would recommend everyone who's watching this, if they're interested in innovative therapies, you can come and take a look. This is one of the diagrams from this. And you could see here an antibody, which is the protein that finds traditionally foreign invaders, but can be done by scientists to find specific proteins on cancer, and then bring in a payload, which is a toxin, a chemotherapy, to kill the cancer cells specifically. Mirvetuximab, called Elahere, was a first generation folate receptor alpha antibody drug conjugate called ADC, and it's worked quite nicely. It had something like 40% response rates in patients whose ovarian cancer had folate receptor alpha high levels. What's coming down the pike, though, is this drug, and there's a lot of excitement about it because, unlike Elahere, which is only for high levels, this one hits both low and high. And so now you could see here this each one of these lines is a different ovarian cancer patient, and they're treated with different doses of this drug. You could ignore sort of the ones in purple here. So really, only 2 out of the patients, and there was probably about 40 or so patients treated so far that they're showing data for, everyone else benefited to some degree, right? These patients here benefited to what they call a partial response. And then even some probably got down to 100% complete response where the cancer disappeared. So this is really exciting. When they looked at the folate receptor alpha high levels, it was 55.6 who had that response rate, meaning below the 25% or 30% here. And then when looking at the low, it was 41%. So still quite good. And remember that there's a whole host of people here who will still benefit from the drug, even though they don't qualify as a quote unquote responder. And we'll see how long that goes for. But this could add months, if not a couple of years, onto someone's life in a way that is tolerable. And again, they're sort of harping on the manageable safety profile here, which is nice. And we'll see more details about this as drugs like this come down the pike and are published in clinical trials. But again, getting access to this early, if you're an ovarian cancer patient, could be really important. And so, encourage everyone to take a look at this.
Yeah, I can't stress enough as I learn more and more that cancer used to be much more of a monolith, and then it was broken into types, and now we're in this stage where it's really understanding what's driving the growth of your tumor, what's happening on the surface of your tumor cells. I mean, this is something where, if I understand what you said, that the first version of this drug was if you were really expressing a lot of this on your tumor cells, then this might work for you. And now it's saying, well, if you don't have all of that, if it's just a little bit of expression, this will work. This should still work.
Right.
And so it's reaching a kind of wider swath of people who are eligible for it. So
Yeah.
that's great.
Yeah. And we've seen this before with the Herceptin and the HER2 situation. And now, with the newer drugs for that, then, it's really exciting.
So I'm going to ask you a question that's outside BRCA, but this is obviously in the subject of ovarian cancer. And someone had asked about the evidence of ovarian cancer starting in the fallopian tubes, and
Yeah.
kind of, is this just a theory? When was this discovered? And kind of off the cuff, I don't know what you can address. We can get back to this
Yeah,
more.
yeah, yeah. Actually, I kind of wish I'd pulled up a picture of this, but that's okay. I'll do it. I'll do some visuals. But in the basically the ovaries in a woman are, and then are attached or have in between that the fallopian tubes, and then they go into the center, which is where the uterus is. The egg goes from the ovaries through the fallopian tubes into the uterus, where the baby can grow and implants in the uterus most likely. Um, where does cancer begin? Cancer can begin in any of those places, right? And if it starts in the uterus, then it's often called endometrial cancer. And what's important about that is it behaves generally differently than, for example, ovarian cancer, right? As we know now, as you just said, it's really, the genes that are driving this. And the fact is that uterine cancer isn't just one, there's carcinosarcoma and there's endometrial and all of these sorts of things. So, again, it's important to get the molecular testing done, called tumor sequencing. And then also, we're now helping patients to look at that cell surface proteins for potentially an attack. Getting back to the fallopian tubes. So cancer can begin in the ovaries or the fallopian tubes. There, they actually don't separate out. They tend to act very similarly. And so whether it starts in the fallopian tubes or the ovaries, I don't know that there's anyone who can possibly say, but it's thought that those are two units that belong to the same classification. As I mentioned before, there's a third, which is called primary peritoneal cancer. This is where they find a cancer cell basically floating around in the abdomen. This might happen in a woman who's gotten the ovaries out. And so they're like, well, where did that come from? Again, it's hard to know. Did it come from the ovary and was just kind of floating out there? And so the ovaries were removed, but this cell made it out and therefore eventually became cancer? It's really hard to tell. But those three, primary peritoneal, ovarian, and fallopian, all belong to the same category and are all treated pretty much in the same way. And so, from my perspective, if there is a patient who has fallopian tube cancer, they should look into the same treatments as ovarian cancer patients, with again getting the molecular typing done, the genetic testing, as well as potentially looking at those cell surface proteins.
Yeah, just to do a really quick pitch. So, when you are diagnosed with cancer, most often of a solid tumor like a fallopian tube or uterine cancer, a little small bit of that tissue is taken. It's sent to a lab where the pathologist will look at it, and they're looking at the cells and they're trying to understand what's going on. And that's how they determine that you have a diagnosis of cancer. That same bit of tissue can be sent for a test called next gen tumor sequencing. And that is a panel of hundreds of genes where they'll test and they'll find out what's driving the growth of this cancer. So that's kind of these days more important. No, I wouldn't say more important, but just as important or a really important factor in treating cancers, because
Yeah.
what's happening in clinical trials is about targeting what's particularly going on in the tumor.
Yep. That's exactly right. And we also have a nice handout about that, as well as another video that we've done before on that topic.
And then the last question I wanted to just make sure we touch. I know we touched on this, but there's BRCA1, there's BRCA2. They live on different places of the chromosome. They're different genes. They both have a high correlation with breast cancer, and we're named BRCA. But the person was asking if the different types of cancers that we mentioned, I think in our promotional materials, like pancreatic, ovarian, breast cancer. So it sounds like BRCA1 and BRCA2 do really have studied different percentages of increased risk for
Yeah.
different types of cancer, and that's something you can look up.
Yeah. And again, even prostate cancer, right? You can see that, BRCA1 really is similar to the regular population, but BRCA2 has an increased risk. We went through the male breast cancer, the ovarian cancer, 40 to 60% versus 10 to 30%. But again, these are both far increased from the regular population. The breast cancer in unaffected women, breast cancer in women um, with cancer in one breast, um, and so you could see how those risks are increased.
All right. So as we close here, I just want to kind of do a final review. And so we kind of got three different situations we've talked about. One is if you do not know your BRCA status. And so it sounds like what we're saying is it's a pretty easy test. It's something that if you felt you had heightened risk, you could ask your doctor to get tested. There are ways to kind of understand if you should do that have to do with your relatives and previous diagnosis of cancer in your family. So anything else to add to that I missed there?
No, and again, it should be easier to find, but try to find this United States Preventative Services Task Force. They abbreviate it, I think, USPSTF. But anyway, on BRCA mutations, go through this and see if you match any of these criteria. Print it out, bring it into your doctor, and say, "Look, I match this criteria. I want to get tested," and then they'll be able to do that.
Excellent. So please do that. Now, if you know you have a known BRCA mutation, Jason, what's your advice to someone who has a known BRCA mutation?
Yeah. Definitely seeking a genetic counselor and their doctor to talk about some of the steps, the heightened surveillance, and the risk reduction surgeries is something that's going to be really important.
And then for anyone who is in the situation of having been diagnosed with a cancer and it is a inherited BRCA cancer, um, we talked a little bit about, but what would you say to them at
Yeah,
this point?
yeah. I mean, this is the sort of situation where having someone who is in a tertiary care center, referral center, someone who sees a lot of breast cancer patients, a place like MD Anderson or Memorial Sloan Kettering in the U.S., or there's many, right? There's lots of NCI accredited cancer centers, but getting someone who is familiar with how to use the PARP inhibitors and has a lot of experience in that is going to be really important. On the other hand, also looking at innovative therapies and asking about what is now available through clinical trials is, I think, very, for some people, especially if they have metastatic disease, is going to be very important. And of course, we're always here. And this is what we do. We help to guide patients so that they have a better outcome, both in terms of longevity as well as quality of life. And so, if there's any questions, we're happy to help.
Yeah, I just say my closing pitch for Sagely Health is that there are amazing things that are going on scientifically, medically, but the future is not reaching us evenly. So there are steps that any cancer patient can do to make sure that they are getting access to the latest diagnostics, the latest treatments, and that's what we're here for, to serve as a guide for those people who want to make sure they understand they know what's out there and they know what's available to them, and we can help find that, identify it, help you understand it, and then help you get access to it. So I hope that anyone will come to sagelyhealth.com. Reach out to us. We'd just love to have a conversation if we can help.
Absolutely.
All right. Well, I think we'll wrap up there. This went about 20 minutes longer than I would have expected, but there was a lot to cover. And yeah, I think this has been great.
All right, wonderful.
All right. Thank you,
Thanks so
JD.
much.
All right.
Take
Take
care.
care.